So I'm really happy to introduce the next speaker, who is Professor of Health Psychology, Marijn de Bruin, from the Netherlands, Radboud University Medical Center. And he's been doing excellent work on using behavioral science in tackling the COVID-19 crisis. Please go ahead, Marijn.
Yes, thank you. Can you hear me well?
Yes.
Yeah, excellent. Okay. Well, yeah, thanks a lot for this invitation to speak here today. It's an impressive list of symposia and speakers that you've been able to get together over these past seminars. Yeah, so my name is Marijn de Bruin, and I'm a professor at Radboud University Medical Center in Health Psychology. But since about 6 months, I'm placed at the RIVM, which is the Public Health Institute in the Netherlands. And I'll tell a bit more about that. We've started a behavioral unit there, and I'm the head of the scientific research. I'm not particularly, from a scientific perspective, an expert on complex systems. Most what I know is by following Matti on Twitter and taking it very seriously and reading the links and everything. But over the last 6 months, I think I have become a little bit of an expert of operating in a complex system, and I know from behavioral interventions that the user experience and participating can actually be very informative when you want to theorize about how things work. So what I want to do today is, if my slides are gonna go to the next, yes, there we go. So what I'm going to do is I'm going to talk a little bit about this behavioral unit that we've got in the Public Health Institute, how it all started. And then I'll share some of our data that we've collected over the last 6 months and try to link that a bit to the first and the second wave, which we are unfortunately facing here. Then I'll talk about the impacts and the challenges of this behavioral unit, and then reflect a little bit on how it is to work on a complex topic in a complex system. So I hope that sentence makes sense at the end. So in February last year, I was a very happy, peaceful academic, and then SARS-CoV-2 entered the Netherlands, and yeah, the last 6 months have been a bit like this for me. It's like being Sherlock Holmes on a rocket, and it's just been an amazing time, but also quite tiring. The moment that I got engaged in fighting against the pandemic is when the first wave was entering in the Netherlands, and in the media and in policy documents, we mainly saw rules and regulations and recommendations very much from a virologist's perspective and an epidemiologist's perspective. And it didn't seem to map very well on human psychology and behavior. So I and a colleague of mine, we then made a little bit of noise, and we came in a policy advisory group, or a more communication advisory group of the national team of crisis communication. And in this group, we discussed with important heads of communication from the policy departments how the messages could be strengthened. But then we were, after 1 or 2 weeks, we were still quite unhappy because we were just a little bit of noise in a very big storm. And then we decided to try and escalate it, because in the Netherlands, we've got a very strong discipline of behavioral science, and we thought it should be at the heart of fighting the pandemic. So we successfully escalated it, and instead of having an advisory role in a communication body, we then started a Corona behavioral unit at the Public Health Institute. So basically in March, we had no formal position in the crisis structure, no name, no money. There were no behavioral experts involved in what is essentially a behavioral problem. I mean, the virus is the problem, but the solution is behavior. So I think that's really important to keep in mind. And then when we started it, 1 week later, we had a scientific advisory board with 15 professors in health psychology, health communication, expertise in specific target groups like young people, elderly people, people with a migration background, lower socioeconomic status, people with expertise in line communication. So we had a very diverse palette professors in our scientific advisory board. 30 behavioral scientists part-time available. At the moment it's about 50, but it's about 20 FTE who are working in our team. And we had time for our seniors. And then 5 days later, so this was at the start of April, we had intensive meetings with the National Core Team of Crisis Communication, the NKC, in The Hague. They're very close to the press conferences and the public health campaigns and the government websites with all the behavioral recommendations. There we presented our theoretical framework for COVID-19 prevention behaviors, which I'll discuss a bit later, and also a taxonomy for these behavioral recommendations. And then 7 days later, we got a €1 million research grant. It's actually possible. We wrote the thing in 3 days. We submitted it at 11 o'clock at night, and we had an okay at 7 a.m. in the next morning. So we can actually speed up science, I think, demonstrated there. And yeah, so not only the virus went like this, but also our group went like this. And it was quite challenging because we were basically already running the shop while we were still trying to find out what our role was and what our science was. So a lot of people made a lot of hours, and then we had this Corona Behavioral Unit, and our mission is to contribute to the effectiveness of COVID-19 prevention measures by making available state-of-the-art behavioral and communication science expertise and helping to translate that for government policy and communication. So that's our core goal. And we don't focus just on the virus. We focus more on, of course, also on the virus and all the compliance behaviors related there, but also more broadly physical, mental, and social well-being. I will briefly run through our scientific foundations. You're not supposed to be able to read this, but at the start of the pandemic, what we started with is there were all these recommendations for washing your hands, keeping distance, etc. But these recommendations were often specified for different populations. So we had asymptomatic people, we had symptomatic people, we had people with symptomatic members in the household. So that's the first branch that you see there, the three division in three. And then for all these people, there were different recommendations for when they were at home, when they were at work, when they were outdoors and doing shopping, etc. So basically our first effort was to try and see what was actually already there, and we made this taxonomy of things, and we could actually discover a lot of things that seemed to be inconsistent, incomplete. Why was it clear for children but not for adults, or the other way around? Why was it clear for in this setting but not in the other setting? And then we evaluated all those behavioral recommendations with let's see if I can get that, yeah. In terms of how specific they were, because we know that if people know a behavior recommendation, what do I have to do, when, where, and why, that when you specify it like that, it's much more likely that people will actually follow up the behavior. And lots of our recommendations came very much from a virology model, like wash your hands more frequently. Okay, compared to what? And when do I have to do that? And or use a paper towel. Well, yeah, for what? Was it for washing your hands, for your nose, or for drying your hands after washing, or wiping your nose? So there were lots of these recommendations that weren't particularly fit to what we know about human behavior. So we scored all them, and then we also scored the difficulty, because some behaviors are just the same everywhere. When you sneeze and you do it in a paper towel or in your elbow, that has to happen always. But other behaviors like distancing are very much influenced by context and by how crowded it is, etc. So some behaviors are quite simple and straightforward, others are much more complex, and you need to take that into account when you're developing your communication strategy and support tools for the population. So we revised all this, and that had a major impact on how all the behavioral recommendations were communicated on the government website and in the press conferences. Then we had our theoretical framework, which is actually part 2 of this scientific foundations. And basically this is a merger of the health belief model, which we use more for the acute phase, updated a little bit with input from our scientific advisory board. And that, yeah, basically it says if people perceive that there's a risk for their health or the health of others, and they got very concrete and clear goals and behaviors, what can you do to reduce that risk, that people are more likely to initiate the behavior. although this becomes more difficult if there's barriers, social or physical barriers, and it might actually help if there's a particular cue to action, like a good press conference or somebody in your environment who talks to you about these prevention behaviors. And the first part is this acute phase, and then there's this maintenance phase. And a lot of the communication is actually stuck in the acute phase, I think, in a lot of countries. But the maintenance phase is so important. So a lot of countries had this first wave. It went down with a more or less strict lockdown. And after that, it was low. And actually, that's when we should have started thinking about maintaining behavior. How can we get support for long-term maintenance? How should we organize the environment? How should we organize work? How should we organize pubs, etc.? And how should we communicate with the population? And that's actually described in that second part, where we have to really look for these motivation, this motive for people to maintain physical distance, for example, and how we can help people form more habitual behavior so that it doesn't take that much effort. So the third scientific foundation, so we had this taxonomy, we had this theoretical framework, and the third scientific foundation is that we made a plan for how you systematically develop these behavioral interventions. And these behavioral interventions can be communication interventions, but they can also be interventions to change the physical environment so that keeping distance, for example, is easier. So we use this template a lot to communicate with policymakers and communication professionals, asking all the time, okay, so if you do this policy, why? How does that map onto the behavior, on the determinants of the behavior, and how does it solve a problem, and what is the evidence for that? So I already discussed that our fourth scientific foundation is our advisory board. Very diverse expertise, as I already mentioned, and they do a lot of things for us in the behavioral unit. And then we have a quite substantial research program with literature reviews. We've got a substantial survey that is on average about 60,000 people complete that survey at every wave. We've got qualitative interviews to complement the survey, and we've got rapid response studies for more emerging topics that need other research methods to address them. So this is the situation in the Netherlands. All the way on the left, you see the first wave. So that started at the beginning of March. And then you see that the number of tests, actually positive tests, is actually quite low compared to at present. But at the beginning, they very rapidly moved to only testing patients in hospital, right? So you know, these figures don't make a lot of sense without knowing these sort of things, because at the moment we're testing all people with some symptoms, and that's a lot of people who have symptoms. So the second wave seems much higher, but actually the number of people infected in the Netherlands is about a third or half of what it was in mid-April. So at the beginning we had what they called an intelligent lockdown, and then when the virus was low, they opened it up step by step. It went actually quite quickly. They actually then also dismantled the crisis structure. And that was for us quite difficult, because we had a very good relation with this national core team of crisis communication, who were very closely connected to the press conferences, etc. And also the press conferences stopped. So and the holidays started. So it was a bit like everybody took off a bit of time. I'm in somebody else's office and the phone is ringing, and I don't know how to switch it off. So we'll just have to ignore it. So I'm now going to map some of our research results on these and see if we can make sense of what was actually happening here. So these are hygiene behaviors. All these pictures, they're in Dutch. I apologize. I will explain them verbally. But so we've got different types of behaviors, and we really see that one distinct set of behaviors are these hygiene behaviors. They seem to be very stable. People find them relatively easy, and they're in support of maintaining these hygiene behaviors for a long time. So here, all the way on the top, you see almost at 100% is not shaking hands, and at the bottom it's washing your hands very carefully for at least 20 seconds, and the paper towel and sneezing in your elbow, etc., is in between. this is what we also do, is that we then look for these behaviors in different contexts. So here you see changes over time in washing your hands in different situations. And you see that for most it's quite stable, but what we also see is that it decreased the yellow and the sort of the orange, the pink or purple line. And these are actually critical moments for washing your hands. They're when you've been outdoors and you come back in your own house. And we see quite a decrease in hand washing at that moment. And also when people visit family members and friends, so they go into somebody else's house, we see quite a substantial decrease over time in hand washing, and I'll return to that later. These are some of the other behaviors, like social distancing and avoiding crowding. And the orange line is the social distancing, and we have got a 1.5 meter rule in the Netherlands. And you see that it decreased slowly over time. Just like the blue line, for example, which is not visiting people or visiting people with a vulnerable health or an older age group in moderation. So all this went down as the virus levels went down. And then the green line was introduced later. Up to that green line, the recommendation was to stay as much at home as possible. And but then that rule was taken out, and it was replaced by avoiding crowded places. And the green line is avoiding crowded places, and you see that it starts high and then drops. And exactly between in that drop, it was the moment when a lot of policies were made more flexible. So it became much more difficult actually to avoid crowded places. So these are all different types of contexts where people say report the degree to which they have been able to keep distance from others. And what we see here, the longest bars on the right are basically being outdoors with children or going for a run, etc. And people find it pretty easy to keep their distance there. But in lots of situations that are indoors, it's more difficult. The most difficult places from the start have been the supermarkets and the workplace. And at the beginning of the pandemic, people also reported keeping distance quite often with family members and friends when they were visiting. But we saw quite a strong decline in that also over time. And we can discuss the reasons for that, but it's, probably you want to be close to your family, and the virus levels were very low. And I'll also get back to that one later. So we've got the hygiene behaviors, we've got the distancing behaviors, and then we've got things that apply to people with symptoms. And of course, there's the recommendation to get tested when you're symptomatic. We basically have this list of very mild symptoms to fever and difficulty breathing, etc. So it's quite a long list of symptoms that are potentially associated with a COVID-19 infection. And we asked them in our survey, and if we look at the last measure that we did, we saw that 26% of the respondents in the last 6 weeks reported having those symptoms. So that's actually a huge amount. If you want to test all those people, it's absolutely, it's really a lot. So 32% of those people went for a test in that period of August, which was 12% in July and 23% in the measure between those two. So actually we've seen a steady increase in the testing, which is a very good sign. 45% of the people who reported to have new symptoms got tested, and 20% of the people who say, well, I actually think this is my asthma or this is my hay fever, they got tested. So it's an important distinction there. 10% of the tests among people indicated, 10% of the tests were done among people indicating to not have symptoms at all, which is not very desirable because it eats capacity in the testing street. And here it's actually a very serious problem, because in September, October, we are really facing a resource issue with the testing capacity and also with tracing people. So the contact tracing. A lot of people had so many contacts, maybe 50 or something, and it just becomes almost impossible for these public health institutes to actually do all the contact tracing. So for people who have symptoms, it's also very important that they stay at home. And here we measured all the places that people went to in the last week, and then basically made different bars for people who had symptoms, which are the dark blue bars. New symptoms. The yellow bars are the people who say, well, this seems to be my chronic condition. and the red bar seems to be are the people without any symptoms. And what you see that there's not really a difference between those bars. So the people with symptoms go outdoors as much as people without symptoms, right? And that's not really the idea, of course. It's really important that you stay at home. So we see that 9 out of 10 people do groceries, and about 40% goes to work, about 60% visits family and friends, etc. So if we try to understand this second wave, what we've seen from the first wave is that we had quite a tight lockdown. Everybody was quite compliant. And then after this first wave, we see it coming up again. And we see that a lot of the infections actually happened in the households, of course, between the family members. Once you bring it in the house, it's very likely you'll infect family members. And but also lots with visitors, family gatherings, in the pubs, and also people who went on a holiday and were traveling. And what we saw in our behavioral data is that in those settings, people had more frequent contacts. So they had more frequent visitors and more people visiting, for example. So that accumulates in many more contacts. And there was a higher per contact infection risk because the 1.5 meter went down, the hand washing declined, and people with symptoms weren't that inclined to stay home. So, and more recent, of course, is that the testing has been slower and that the contact tracing is not feasible anymore in many places. So that just then escalates. So new policies have now been implemented, particularly limiting the number of people allowed in different places, like in restaurants, but also in the households, and recommending face masks, which is a whole different story in the Netherlands. They're a bit of an outlier there. Because yeah, the medical teams think that there's not a lot of evidence to support the wearing of masks, face masks. So a little bit of the psychology behind it is so what we're seeing here are risk perceptions, and we have the how probable is it that I actually contract COVID is the bottom line. So that I get infected, and actually it's correct. You know, it's not very high that you actually get that you become infected. So that seems maybe pretty accurate. Then the yellow line reflects that. Well, if I have the virus, how likely is it that I'll transmit it to others? And then the top line is how bad is it for you? How serious is it for you if you would actually infect somebody else? And you see that these 3 lines are very stable. The one line that actually increases is a severity score that's related to how severe people think it is to actually become infected with COVID-19. And that's probably because there's more and more news on people with long-term consequences and impacts of having an infection, even when you're younger. Here we see the risk perception of a second wave. So the yellow line is how bad people think it would be, and the bottom line is how probable people think it would be. So that's obviously increased. This is more the emotional response to the threat of the virus, and you actually see that initially it slowly went down when all the numbers were low, but then when the numbers came up again, the emotional threat of the virus also went up again. And that's actually a pattern that we see in quite a few things. We're also measuring response efficacy. So that's how effective people think these different behaviors are in reducing those risks of the virus. And these are the hygiene behaviors again. And you see that that's actually pretty stable. And here are more the social distancing behaviors. And also here you see that as the virus went up again, you see that people think that these policies are also more useful again. This is the support for the policy. Again, you see that for the hygiene behaviors, it's actually been very stable, but for the social distancing behaviors, the support for the policies went down. But as the virus went up, the support for the policies went up again. I think it's also important that we just don't only focus on those behaviors and those cognitions and emotions about the behaviors, but also a bit about the larger context of well-being. This is loneliness. And actually you see that during the the lockdown in April, loneliness, somewhat or severe loneliness was pretty high, and that all these rules were made more flexible again, and we had more visitors and we did more outdoors, there was a huge drop in loneliness. So that's actually a very good thing about releasing those measures. But yeah, it does seem to come at a cost. And we also looked at the lifestyle behavior. So initially we saw that a lot of people reported that they were exercising much less than before because of the lockdown. And then that's the top line that you see here on the top figure. And the number of people who said, well, I'm exercising much less than before the pandemic has dropped considerably, as you can see there. And people have increased smoking. My guess is that it's because we're working from home again, and so much. And actually, you can smoke at your home office, but you cannot smoke in the office. I think that's an important factor there. So it's really about trying to balance all these policies for fighting the virus with all those other factors that are also important for our well-being. So that was our research, and then a little bit on the impacts of the unit. This is an example where we combined our quantitative and our qualitative research to better understand why people with symptoms were not staying at home and were not getting tested. So we saw that about 10 to 15% of the people with symptoms were not staying at home, and about 10 to 15% were getting tested, and 3% did both. So they got tested and they stayed at home. And we did research on why that was the case. And then also with the people who are modeling the virus, we came with a couple of key messages to address those determinants, like how much does it help? So last week, about 5,000 people got tested. How much does that help to fight the pandemic in 6 months? And we could actually put some real figures on there. And we went on the national news, national radio, newspapers throughout the week. And here you see the number of tests. And in week 29, we did our intervention. And there was an increase in 40% testing the next day after we came out with our message, and 60% 3 days later. And you see another jump at week 34, and that was after quite a strong press conference by the Prime Minister. So we also contribute to national campaigns. We helped formulate the government websites, and we were quite closely involved with the press conferences until the National Core Team of Crisis Communication was dismantled. So we haven't been there that involved lately. At the policy and societal level, our impact has been a bit more modest. In terms of a societal impact, most of our impact is through our appearances in the media. So I'm the spokesperson there. But we also have this scientific advisory board of 15 professors, and we keep them very well informed on the latest literature, our research, etc. We have discussions every now and then. And actually, if you look at the total number of times that we've been on the radio, TV, I mean, it's just like hundreds of times. So I think that together we've made the behavioral science very visible in this situation. But the key thing is that we aren't very much involved in the policy making yet. We haven't been able to get into the policy processes yet. So my last reflection is that, this is a complex topic in a complex system. And it's a complex topic because we've got multiple behaviors and there's the psychology involved, but there's also the physical environment that we see is really important with crowding and distancing. We've got the social environment. And all these things seem to interact. So places where it's more crowded, it's more difficult to keep distance. It also seems the social norm is against distancing, which leads to discontinuing the distancing. It becomes more crowded and you get sort of in a downward spiral. And there's also these costs of unhealthier lifestyle, loneliness, anxiety. So it's really a complex thing to manage all these things at the same time. And the second what I want to say about a complex system is that we're actually trying in this to implement behavioral science. And that has proven to be really, really difficult. So it's quite indirect. We often have a secondary role. It's more on the communication after the policies have been made, whereas you can really see the added value of behavioral science actually in the moment that you're shaping the policies and the recommendations. We're not in the medical unit making the guidelines. We're not at the key policy tables, But there's a lot of noise in the media and from many experts at the moment. So it's it feels like we're almost at a tipping point, to stay in the theme of this symposium, where it wouldn't surprise me if in the next couple of weeks this whole situation will change drastically. So in sum, the problem is the virus. The solution lies in human behavior, at least for now. But even if there's a vaccination, people need to get vaccinated, and that's not obvious that everybody will do that. We weren't part of the core disciplines in the Dutch response initially. There's a huge amount of knowledge and expertise. Everybody who I approach at a university immediately says yes, and they drop other stuff and they just go for it. So there's a huge resource that we need to tap into. It's very complex to navigate with all the disciplines, the emotions, the pressure on policymakers, and the duration. You really see a lot of people being very tired working on this pandemic. There's increasing pressure to place behavioral science as the heart of the response, together with virology and epidemiology. I always like to show this picture. It's a bit with a, you know, you see here the first wave, and the intelligent lockdown happened at that time point. And then when we really started our strong collaboration with the National Core Team of Crisis Communication, we revised the website, we entered a series of really strong press conferences that we actually started. That was exactly 2 weeks before the curve went down again. So I'm not saying there's a causal effect. I'm just saying it's probably coincidence, but it's a nice one to show. Thank you.
Thank you very much. It is. I still haven't kind of gotten used to not hearing the applause after the talks. Excellent talk. Thank you so much. Let's take a few questions for you. There is in the question and answer box. Can you see from Sandra Hermsen? Thank you for a hugely interesting talk. Why won't the Dutch policymakers adopt face mask wearing? I feel as if the OMT doesn't know the difference between absence of evidence and evidence of absence. What do you think?
Well, I think it's not my role to comment on that, because I'm the behavioral science, and we have got a very clear role division. And I think that everybody should stay with their core expertise and then collaborate. And so how effective masks are, that's their decision to make. And in terms of the behavioral effects, because there have been discussions, maybe a false sense of security with those face masks, maybe people let go of the distancing. How do you ensure that people use it safely and don't touch their face all the time? That's our role. And yes. And also support the compliance and safe use of the mask. So I think this is a question that's for somebody else. Yeah.
Thank you. Then Matthias Albach is asking, how does loneliness vary across the year in normal years? To what degree is that change in loneliness due to Corona or just normal seasonal effects?
Right. Yeah. That's a good question. Yeah, I can imagine that that in the winter it may be a bit more. So I don't have that answer ready. I just have my observation is that it seems to me be very unlikely to see such huge differences in loneliness that coincide with relaxing those more. But I think it's a very good suggestion because we're using a validated scale that is also used in other national surveys. So it's a good idea to plot those against each other. Yeah, thanks.
Great. And then there is a question from Kwok that the issue about the noise from media. How confident are you with the findings you make into mass media?
So
wait, so the thing is that probably can you try me to unmute Kwok to explain the question? So I think that because there is so much news all over the media and so much, so even though you have like hundreds of media appearances, what is the reach to the normal, like average person?
Right. Go ahead if you want to.
Yeah, no, I think Nelly covered it in a more sophisticated way. I was trying to make make use of words of using make and make. So the findings you make and make it into mass media. So how does it reach the media when you talk about the noise and almost it sounds like you're fighting against the noise or you're within the noise. I don't know. Some clarity on that would be nice.
Yeah, I think the thing that stands out for me is that that the media have made a lot of use of our scientific advisory board and of our research results. And I always say that when you invite me on a program on the news or in a newspaper, I always, or on the radio, I always say to them, I'm going to be a bit the boring one, because I'm collecting data, and we actually see that it's not like yesterday was a nice day. There were lots of busy places. Oh no, the Netherlands sort of let go of everything. And I would say, well, actually, people can have a day like that. But if you look on average, we see that it's much more stable. And so I think we have had a normalizing effect on some of the more the sensational type of interpretation of behaviors. I don't know. I think that if you look at the moment that we came out with the testing results and that message, and we went on 3 or 4 national radio and national TV and 4 or 5 newspapers that were also to different parts of the population, that immediately the day after you see such a jump in the testing that nobody really understood, except for that it was related to that. I do think that there's an opportunity to get through this noise, as you say, and that's probably also because it's the National Institute of Public Health. So it's different from when you have a message as a university professor when you speak from this institute.
So thank you very much for the great answers and great questions to the audience. There are some more questions. I'm not sure if, Marijn, do you have time to type in some answers, or do you have to fly to your next meeting? But yes.
Can I ask one quick question?
Oh, go ahead.
What do you think about, because it's always the easiest to motivate people into restrictions when the virus is high, and as you showed, things got very different when the virus levels got low. So what should we do now when we beat this wave and then we go back to the thing where it looks like it's almost over and people start relaxing, but that's the most important thing to get to 0 from something?
Yeah. I mean, I think we start to know more and more in behavioral science about maintenance of behavior. So if you've followed the crash diet and you've lost 30 kilos, and then you get into your normal life again and you have to maintain that, you sort of have to adjust your goals. So you want to have sort of a long-term goal. You want to know very concretely how you're going to get at that goal. And ideally, you would like to have some feedback on how much you have prevented by keeping those goals. So at some point, the virologist modeled how many hospitalizations have we prevented by actually following those rules. And then they said, well, it's about 30,000 hospitalizations. Well, in Netherlands, that would have completely shut down, society. So I think this type of feedback, and not always focus on the risk, but actually focus on what is it that we don't see that we've managed to do together, and make that very concrete and for people, maybe also with personal stories from people. And I think that's and engaging people and taking them very seriously, also their concerns and the hard side of the regulations, and can we tailor some things more so that we make it more feasible and realistic for you to maintain it in the long run. So I would really focus on that second part of the model, the maintenance of the behavior.